Okay, so you can literally go back and start solving UWorld and NBME, so you're going to be outperforming everything. Okay, then endocarditis cheat sheet. Okay, so fever plus murmur plus IV drug use history. What's the bug? I'm talking about the bugs. What's the bug? Staph aureus. Staph aureus. Okay, remember, aureus is catalase positive, coagulase positive, okay, and has protein A, which binds to the Fc portion of IgG and prevents phagocytosis. Aureus in particularly causes tricuspid regurg, tricuspid regurg in IV drug users. Okay, then fever plus murmur plus history of some valve problem. And remember, Staph aureus, I'm going to bold this up, targets normal valves. Okay, targets normal valves. A history of some valve problem, and recently underwent some dental procedure. Mariam Mahmood, listen to the question completely. Viridans, yeah. So strep viridans. Okay, so viridans is beta hemolytic, optochin sensitive, bile. I don't remember the bile point, whatever. Okay, and what is the other beta hemolytic drug bug you know? Yeah, bile insoluble, yes. But what is the other beta hemolytic drug bug you know? Basically a group B strep, strep pneumo. Very good, very good. Okay. Then fever plus murmur plus underwent valve replacement 6 months ago. Bug. What are you thinking about? Staph epidermidis. Staph epidermidis. Okay, epidermidis. Now here I again forgot to mention targets previously damaged valves. Like, and they can easily give you a question. Patient has like fever and murmur, and previously the patient had like a mid-systolic click on auscultation. So it should basically like point you towards. It basically should point you towards thinking this was a damaged valve. Okay. Then let's see if anyone can figure this out. Fever plus murmur plus negative blood culture. Let's see who's a master at micro. Coxiella, very good, Coxiella. Okay, so Coxiella is combo. Okay, so I remember the buzzword for Coxiella. Hepatitis plus pneumonia plus no rash in a patient who deals with farm animals. Okay. Then fever plus murmur plus recently underwent some genitourinary procedure. What are you thinking here? What are you thinking here? Very good, enterofocus. Okay, very good. Then fever plus murmur plus underlying colon cancer. What are you thinking here? Bovis. Okay, strep bovis or galoiticus, whatever you call it. Okay. Are we left with anyone? Let me see. Okay. Then empiric treatment for endocarditis, infective endocarditis. What do you want to do? What do you want to start the patient on? What do you want to start the patient on? Like into antibiotic therapy. Why ceftriaxone? Is this? Are we talking about strep pneumo or Neisseria? Vanco plus what? Vanco plus what? Gentamicin. Okay. Note, extremely high yield to know. If the patient has history of prosthetic valve placement, add rifampin. Add rifampin. Okay, it's a DNA dependent RNA polymerase inhibitor. How do I remember it's RNA polymerase inhibitor? Because it's literally in the name R. R for rifampin, R for RNA polymerase inhibitor. Okay, so it would look something like Vanco plus Genta plus rifampin. Reminder, rifampin is also used for prophylaxis against in close contacts with Neisseria meningitidis and Haemophilus influenza. Okay, another reminder, rifampin is hepatotoxic and causes red urine, orange urine, orange urine or tears. Okay, I've seen this clinically happening to a patient. Then, what what if I give you a question where a patient has infective endocarditis and now ECG shows PR interval prolongation? What is the diagnosis? What are you thinking here? Any ideas? Anyone? Okay, so I don't see any answer. Is basically paravalvular abscess. Okay, paravalvular abscess. So buzzword would be PR interval prolongation in a patient with infective endocarditis. Okay, and the symptoms for IE is basically easily remembered by the mnemonic from Jane. So look out for like fever, Roth spots. These are basically bilateral retinal hemorrhages. Bilateral retinal hemorrhages in a newborn. What's the diagnosis? Anyone? Yeah, subdural hematoma secondary to shaken baby syndrome. Okay, then O is for oscillar nodes. Remember, these are painful. M is for the murmur itself. J is for Janeway lesions. These are painless. A is for anemia. N is for nail bed hemorrhages, and E is for embolization. Okay. Then, what are the surgical indications for infective endocarditis where you have to take the patient in for surgery? So, what do you think? Doesn't matter, any bug, doesn't matter. So one I just told you, so a paravalvular abscess, it's an indication for surgery. Then second, anyone? So severe heart failure from regurgitation. Okay, difficult to treat pathogen, like let's say it's a multi-drug resistant bug. Okay, and then the other one would be let me remember, what was the other one? Very large vegetations, like greater than 1 centimeter, or persistent embolization despite antibiotic therapy. Okay, is this endocarditis clear? Is this clear? Okay. Then another thing I want to bring to your attention. See, how do you differentiate infective endocarditis from Liebman-Sack endocarditis? Like, how do you differentiate? Anyone? Okay, tell me what. Eosinophilic doesn't, not necessary, exactly. Himani is right. Okay, so remember, for infective endocarditis, Q stem will mention echo reveals vegetation. Okay, infected vegetations with organisms. For LBSE, they will say Q stem will mention sterile vegetation. Sterile vegetation. This is extremely important to remember. Then, two conditions associated with LBSE. What are the two conditions? Advanced. So Mariam remembers the literal U word answer. Advanced malignancy. Okay, SLE. But the advanced malignancy, Mariam, the particular one is basically pancreatic cancer. Okay, very strongly associated with it. Two signs for pancreatic cancer. What are those?